Yeah, so good afternoon, everybody. Welcome to this Canon Symposium on the future of interventional cardiology imaging. I'm really glad to welcome you with my colleagues, Dr. Advek from Switzerland and Dr. Schuller from United States. So today we're gonna, in the next 45 minutes, we're gonna deal with some potential options for improving the quality of our procedures. The future of the interventional cardiology will probably rely on getting a better image, and the paradox will be also to be able to reduce the dose and to reduce the contrast amount, the amount of contrast used in the procedure. So now we have some potential solutions that will help us to achieve these objectives, and we're going to start right now with Dr. Advek, who's going to present us the Alphenix Evolve technology.
Yes, Mr. Chairman, ladies and gentlemen, dear colleagues, thank you very much for the opportunity to talk on a hot topic, artificial intelligence, and to share some of our experience with it from our cathlab with you. Thank you also for the sponsor to have set up an interesting symposium. These are my conflicts. So I guess in the cath lab we want excellent image quality. At the same time we want to reduce fluoro and radiation doses. Now the combination of the two things can sometimes be a bit tricky, particularly in the low dose settings such as fluoroscopy. Noise there is definitely an issue. And this is where artificial intelligence is coming into place with its ability to do fast computing and apply all kinds of complex algorithms. It may reduce noise and as such improve image quality. Now, don't blame me here, I'm not an expert in this at all. But to what I understand is that machines need a target and machines need also some input. So in our case, this would be the noise level of a cine run, which would be the goal for the machine, and we will feed the machine with fluoro images. And then is this kind of magical thing going on, this black box, this convolutional neural network, also referred to as CNN, which does in fact something no one really does know, but it seems to work, and in the end we come up with very nicely processed images of that initial fluoro resembling almost a cine run. So this is actually what has happened in the laboratories. This is actually the training phase. But the good news is when you get Evolve, you will get a server which has been trained in this and which is able to process raw fluoro data immediately. So here's an example. You put your foot on on the pedal, you get a raw fluoro data. The data is immediately processed. There's no time lag, nothing, and you will come, and the machine will come up with an enhanced fluoro. You can see the difference actually. Once again, sorry. You have. This is the raw data, and you have a clear improvement in contrast to noise ratio that can be as high as up to 2 times. Now, what does the whole thing look in the cath lab? The decision you would have to make is whether you would want to use a regular fluoro or whether you want to use an enhanced AI fluoro. So basically you can turn it on and you can turn it off, obviously. Then you can decide between 2 or even sometimes more modes of AI, a bit more aggressive ones, a bit more ones that are more similar to what we have been, or to the fluoro that we know. And that's basically it. The dose of the fluoro so far in our institution was set at the same level, but you can, like always and like previously, you can increase the fluoro rate, and you can of course also increase the frame rate of your conventional cine runs. Here you see the foot switch. Here you have the fluoro, and depending on what you have selected, you have a regular fluoro or you would have an enhanced fluoro. In the middle you have your cine recording or digital acquisition, what it's referred to with Canon, and on the right side you have a fluoro recording of the enhanced fluoro images. We're currently running a clinical evaluation phase. We're seeking answers to two major questions. Does this technology improve the overall fluoro image quality, and particularly the visibility of what I refer to as interventional tools or interventional stuff, such as guide wires, balloon stents, and so forth? The second question is the AI fluoro image quality sufficient to replace cine runs to a certain extent? And I can tell you, yes, it can, but first of all, two remarks. Once again, the fluoro dose settings have been in all patients the same, and we have been using in all patients the same contrast media, which is iodixanol 270, so Visipag, which is already pretty diluted. Now let's go on and have a look at some images and how AI fluoro performs in coronary angiography. Now here's the thing, here's a fluoro recording, and at the same time there's a cine run. So my question to you would be, which one is which? So who thinks that the fluoro is on the left side? Put your hands up, raise your hands please, so that I can get a feel. No one there? Okay, that's good. Hey, excellent audience. And then, so my question would be the other one who thinks that the fluoro recording is on the right side. And I see a lot of hands. Wow, you're good. Yeah, I think it's not that easy, but I can give you a hint again. It's the image is much brighter. You see also some structure fine structures that are a bit more augmented, and you have a clear definition of the vessels as well. Now, sorry, actually that was too fast, but what I wanted to point out actually is that even that the image quality is so similar, the good news about the whole thing and the exciting thing about it is, of course, you have a lot less of dose. It's almost ×5 less of dose because you've been doing a fluoro recording instead of a cine run. And I think that is something pretty exciting. So I come to or with other words, you can do 5 fluoro recordings and get the dose of 1 cine run, and that's exciting. Now here again, dose reduction, it's the same setup. On the left, it's a cine, on the right, it's the AI fluoro. What I wanted to point out is in this case that obviously you have a occluded right and you have some collaterals, but you can also nicely depict them here on the fluoro recording. So the information that you need is there with much less of dose. Here I want to draw your attention to the stent, stent being formally implanted, and again here I think it's even better visible on the right side in the fluoro recording than in the conventional cine. Here's a very obese patient, a BMI of 37, and I think that it's a pretty decent image. Again, there's a dose, reduced dose as expressed by this air KMR by frame, which is actually probably the best indicator because that's the dose that hits the patient. Now we want to see how does AI fluoro perform also in PCI. Here's a similar situation, the same patient it's almost the same setup. Here actually it's a stent being placed to the proximal LAD. Over here it's only the balloon doing predilation. But I think there's no big difference in image. In fact, I think again here you see the wire much sharper. You see this previously implanted stent much clearer, and you get to see the balloon and the markers very clearly. So I think also in PCI it works very well. Here's another scenario. It's not exactly the same thing. It's the same anatomy, the same patient. Obviously here's a PCI going on in the proximal LAD, but that's not the thing I want to show you. I want to again draw your attention to the calcifications of the lesions. What I think they are even better visible in the enhanced fluoro recording than in the conventional cine. Here's a very obese patient, 41 BMI. Here's obviously PCI going on in a diagonal. As the PCI moves on, there's a second wire in this patient going to the LAD, and there's a lesion being prepared in the mid-LAD. I think the image quality is really good so that you can be really sure of your landing zone and do a proper lesion preparation in this patient. And same is of course true for the positioning of this stent. That again is nicely shown in this fluoro recording. Again, a large drop in dose. I mean, a lot of those being those being reduced. Now I have shown you a lot of images of the left coronary system. You have to believe me that the system works also in the right coronary, as you can see here. It is a nasty lesion in the mid RCA. There's some calcifications. There's also some dissection to it, and the flow is a bit reduced. But I think you get all the information you need by doing only a fluoro recording. And I think it is really fascinating to use this system. Now, another example, I just wanted to show you that balloons look the same. On the left, you have, in fact, it's a stent being implanted. On the right, you will see a ballooning. But on the right, again, the image is much more, it's brighter. And to some extent, the structures are more well defined in the fluoro, in the enhanced fluoro. Here's a bit of different settings. Those are two fluoro imaging. On the left, you will see the positioning of a stent in between two stents. You see a nice overlap of the stent being positioned, and on the right you can also appreciate the overlap, and at the same time you see clearly that this stent is underexpanded and would need some further work to it. Another question we were asking is, what about dose-saving techniques that exist already? Is, for instance, this spot ROI. This is a Canon thing. It's more or less a filter. You can put it and use it during PCI. It will reduce the dose in the region of less of interest, and by this you reduce quite a lot of dose. The system has not been trained for this. Again, we have been using it, and you can see it works nicely. The images quality is as good, when even better, I think, than with conventional cine, and again, there's a huge reduction in dose. So I have shown you a number of examples of everyday scenarios that you are all, I'm sure, familiar with. I can tell you we have applied this technique in all those scenarios, and we have been very happy with it. before closing, I wanted to show you some data, but having said this, this is a very early evaluation phase. We're currently overlooking about 1,000 patients. About 200 of them have been undergoing angio or PCI with this AI-enhanced fluoro. The good news is actually that we were not forced to change our routine at all. We do what we have been doing previously, and this is reflected in the data, the patient's characteristic. There's no procedural differences. However, and this is exciting and not surprisingly, the overall dose has come down, and this at this very moment, and this early preliminary analysis is true for patients undergoing coronary angiography, which of course is a much more standardized procedure than it is a PCI. So it's about a 30% dose reduction. Now you would argue, well, come on, you have shown us about a reduction of 5 times. Yes, that is true, but don't forget, the system has been developed to clarify the images and reduce and dose reduction is a nice side effect, but in order to but still fluoro is fluoro, and in order to get a reduced dose you would have to use fluoro recordings instead of conventional cine runs, and you can imagine this has been an early experience. There's a lot of different operators having to get used to that, and I'm pretty confident that the data is is going in the right direction, and I'm sure it will eventually lead to a big dose reduction, and at the same time improve our image quality. So with this having said, I would like to summarize that enhanced imaging with Alphenix Evolve in the cathlab works with a clear improvement in general fluoro image quality. There is enhanced visibility of interventional stuff, as well as improved identification of calcifications. There's also a potential to significantly reduce the number of cine runs by replacing them with AI fluoro recordings. And as such, of course, there's a huge dose-saving potential. Just remember, again, it's about 5 times less of fluoro compared to a cine run. And in addition, it works well with other dose-saving techniques such as spot rise, for instance. So thank you very much for your attention.
Thank you, Lucas. These are fascinating data. I'm quite rather sure that there are some questions in the audience or remarks, or please go to the microphone. Yeah.
Great talk. Thank you very much. I think it's getting to the point where we don't talk about fluoro or cine anymore. It's all just digital acquisition. It's not like when I started 40 years ago and one was analog and one was... But one question I asked, it looked beautiful pictures, and all the high energy, high kH, like the wires, the calcium, look very sharp. And obviously the AI libraries is picking that type of energy levels for that type of atomic structure. But what about the soft plaques and things like that? Did you find, because look at the pictures, a lot of the soft areas contrast seem to be lost in the low range and a lot of amplification in the high range, like wires and calcium. Did you seem to lose that ability to see soft plaques or thrombus and things like that using that?
To be honest, I think it's an excellent question. So far, I think we are learning with it. I can't give you a proper answer. I think so far to what we needed to see, we have seen it. I think the information was there, but I can't give you a particular answer to the question, but I think it's a great question, yeah.
Well, it's the world of IVUS now and OCT anyways, but I suppose you always go back to acquisition if you're worried about if you couldn't see that type of imagery, you'd just do a DA run. Did you find that sometimes the fluoro, and then you go for the other pedal and do an acquisition run? Or did you have multiple energy levels on the pedals?
Yeah, no. Sometimes we just do a cine run to confirm it, and I think it's initially it's a try and error. But again, you have it's you don't add too much of additional radiation. So I think at this stage it's fairly feasible to do it. So,
Thank you. Great talk.
thank you.
Maybe do we have? If we don't have any other question, I would like to ask you one question. Do you have the experience of this technology for CTO, for example? Do you think that the CTO PCIs are probably the best application for this Evolve technology?
Yeah, absolutely. I think we have experience. We have antegrade. We have retrograde experience. I think it's very useful in these cases. To be perfectly honest, and that refers a bit perhaps to your question before, sometimes, and because it picks up, let's say, structures very well, sometimes, for instance, crossing the lesion might be a bit more difficult, because sometimes it can be a bit of busy, the image, and depends also a bit on the mode that you are selecting. And there, sometimes we tend to use a conventional fluoro, but I think it's just you have to get experience with it. But after that, and I mean, this is on a very short moment of the procedure, but after that, with put the virus, you go through the sepals or whatever, it is perfect.
Okay, thank you. So if there are no further questions, we can move. Oh, sorry.
Yes, it is. Yeah.
So now I think we can move to the next presentation about fusion, imaging fusion with angio-CT, and the talk will gonna be delivered by Brian Schuler.
Really appreciate the opportunity to get up here and speak about this. This is something that we've been very passionate about. We had a angio-CT suite delivered we started in December of 2019. And one of my former partners was able to convince the healthcare organization that this was like the future of cardiology. He was very far in front, and we got started with him. Then he went back to Emory University, where I trained, and then it was sort of up to us to kind of figure this out. So today I'm going to talk to you about intraprocedural CT-guided appendage occlusion. This is not, pre-planning, and then we're going to use that pre-plan to figure out what to do. This is actually using the CT to guide the procedure itself, and I'm going to try to convince you that this should be the new gold standard. These are my disclosures. So the objectives, we're going to demonstrate the utility of the angio-CT suite for appendage occlusion procedures, including de novo LAAO procedures and closure of peridevice leaks. I'm going to show you why it's important, reviewing the data demonstrating the clinical impact and incidence of peridevice leaks. And then I'm going to show you our data to suggest that this should be the gold standard with PDL rates that are as low as you will find anywhere. So the suite itself is very important to talk about. So you have the Acquilion 1 16 centimeter volume scanner, coupled with the Alphenix Sky ceiling mount C-arm, and it's a unified table. And so you can imagine that you could do a CT in that room, you could do a fluoro-based procedure in that room, but the real magic is when you combine those two modalities. This is volume scanner is the best friend of a structural heart proceduralist. You can get 16 centimeters of volume, and you can dial it down if you don't need the full volume. This is the team that really assembled to tackle this issues. How do we launch this? How do we create procedures with this if you had the big blue ocean in front of you? And I myself am an electrophysiologist. I find myself among our interventional colleagues, but my partner, Stuart Benton, he's an IC, and Dr. Chaudhary is a Brigham-trained advanced imaging. So Stuart and I, first thing we got this system, we figured we don't know what we're doing here. So we went out and got CT boarded. So we're level 2 boarded, and Madi is a level 3. This is the suite itself is an integrated diagnostic and therapeutic arena. And the list of things that you see on the left are things of really convenience. Imagine doing same setting coronary CTA and PCI at the same time. We've done proof of concept on that. How about TAVR workup and a TAVR at the same setting? We've done that. Same setting CT cardioversion. We published the largest consecutive cohort in humankind in JACC imaging. And then same setting CT of the appendage with left atrial appendage occlusion. You could see the list of things that are possible. But what really gets us excited, what gets me excited, are the novel CT-guided procedures. And today I'm going to talk to you about intraprocedural CT-guided left atrial appendage occlusion. So the most important thing to remember is that all leaks do matter. If your goal is to occlude the appendage, you've got to occlude the entirety of the appendage. You can't have peri-device leaks. Chris Ellis at the Vanderbilt group really found that in their patient population, they had 1,000 patients, and they had a 3 times incidence in stroke in patients that had leaks. And how big were these leaks? Well, they were under 3 millimeters. And the confounder is that in their leaks that were over 3 millimeters, over half of them were anticoagulated. So with that data, the Watchman Working Group went back and looked at it, and they found that if they had a peri-device leak at 1 year, it doubled the risk of stroke at 5 years. What about prevalence? Look at this slide. It's pretty disgusting. We have, there's so many leaks that it's kind of insane. And I'll even give you, this is European data, and this is Swiss Apero, and there were 50%, roughly 50% incidence of contrast penetration into the appendage, and a clear about 30% of peri-device leaks. So this is what it looks like. This is the first one we ever did. I'm in their lab with my partners, and I said, well, what if give me that CT injector. So we connected it to the side port of the sheath, and we injected it. And if you see this, it's striking, right? It's amazing. You can see the transeptal puncture, where you cross the septum. You can see the appendage. You can even see the TE in this picture. You get the ejection fraction. This is 16 centimeters, full volume coverage. There's nothing like it. When you see this, it's amazing. And so we presented last year, I presented this at ACC, and I'm going to take you across this slide, and it's a very well sort of organized slide. Look at it by rows. So what it gives you is the power to know that you're perfectly aligned. So the first row shows a case where we deployed the device and we had axial misalignment. So we're able to correct that because we're still on the cable. So it allows you to correct your mistakes of alignment. The second row across, you can see that this one here, we thought we were good, but we didn't have a lot of PET fabric contact. We gained a couple of millimeters, and we ended up with a perfect outcome. And the third one, that's something that we've kind of coined as flaring. We completely changed the conformational shape of that device. If you see the third image there on the bottom, you could see that we took the device, the Watchman device, and literally smashed it, and we changed it from the second to the fourth. We completely changed the shape of the Watchman. In order to do this, you have to be up against the back wall, and we've never done this with an amulet device, but just to show you that is completely possible, and we flare these devices all the time. I'm going to take you through a case of misalignment. It's a typical patient for left atrial appendage occlusion. This is a reverse chicken wing, requires a low anterior stick. You can see here, on TE X-plane, a low anterior stick. And then I'll just show you, this is the angio and the tug test. And honestly, the TE images here were a little bit challenging in the high views. We really couldn't get good acoustic windows. So with that, if you looked at this, kind of a 90 degree-ish, like 83 degrees, would you release this? And if you just said yes, you'd have had this result. So CT is not limited by acoustic windows. This whole process to get the CT is 6 minutes, 3 millisieverts of radiation, and 40 cc's of contrast. And you could see the end of the PET fabric. You could see that there's a 100% chance of leak here. And so we repositioned the device after repeating the transeptal puncture, going down by the aortomitral continuity. And these are the two differences. So imagine on the left, there's 303 Hounsfield units in the appendage, 302 in the body of the left atrium versus 422 and 222 inside the appendage. It's dark. You can see it's working. It definitely has some wire bias. We figured we let this go. It's going to orient itself correctly. And of course, this is what it looks like in 4 months. No leak, no device-related thrombus, and the appendage is occluded. Here's a case that Dr. Benton was going to present at SCAI. Unfortunately, he got sick, so he couldn't do it, so I'll do it in his stead. But he put this case together. We did this together in January of this past January of this year. And so we had an outside CT. We use whatever we've got. Here, representative TE anatomy, and this is kind of par for the course for us. If you look at the bottom right image, it's kind of missing a wall. It's really short on the one aspect of the device. Here's the angio and the measurement. So this thing really opens up. We tried a 35 millimeter Watchman device. It was too big. We took it out, we put a 31 in there. And these are the TE views. And so if you look at the TE views, and I've got all the representatives, 0, 90, 45, and 135. If you look at that, there's really nothing here to tell you. Maybe it's getting close in the 132. Here's a CT. And this is like what we do. We just acquire the thing, then we walk down the device. So what we'll do is we'll start in the left panel. We'll start there. You can see we're still on the cable, complete ability to reposition this. So we'll walk down the device after getting 2 orthogonal views. You can see there's white on the outside of that device. There's a gutter that's going pretty deep. And normally we have the multiplanar and you can see the crosshairs, but we'll do, for the sake of this presentation, we're just gonna go through it one at a time. And you can see that the contrast is starting to come up along that middle panel. But when you see this lateral projection, there's absolute, clear, 100% evidence that it's getting past the PET fabric. There's just absolutely no doubt. This device needs to go in and basically turn a little bit to get oriented properly. So what do? Well, we said, maybe this isn't the right device for a Watchman. We can't get it to work. So we tried Amulet. If you look at it, we couldn't even get it to pass the release criteria. We tried a 28 and a 31. And then just for, old time's sake, we gave it the old college try. We went back to a 31, and we stuck lower and more anteriorly, and we deployed this device. And these are the TE images of that second deployment of a 31 millimeter device. And if you look at it, it looks pretty similar to the original one. But we actually think we may have gotten it. And in this case, we said, you know what? There's not a lot of PET fabric contact, but this patient really needed this procedure. And we said, if it leaks, we'll come back and we'll seal it. Fine. But here we are at 3 months, and look at this result. Only 6% compression of this device, but it's fully occluded. There's no DRT. It's perfect. And I think, for us, this is where it's at, is the perfect result for that patient. They don't have to come back for a second procedure. And you can see on the far right how that contrast is trying to get up past that PET fabric, but it can't. One little plug for Watchman, the Flex Pro actually has about 1.5 millimeters of extension of the fabric, so it's a little bit longer. We think it probably really helped us here. So I'm going to ask this question. The one on the left is 100% a leak. The one on the right is a complete seal. And can you tell the difference between those two? We can't. One thing to know is that CT is roughly 30% more sensitive than TEE at detecting peri-device leaks. This is Jackie Saul's working group. She found almost concomitant CT and TEE, 44% PDL rates with CT versus 34 by TEE. And in our data, the first 330 consecutive Watchman Flex devices, we have a single-digit leak rate by CT, which is pretty much unheard of. I'm going to show you how we close peri-device leaks. This is actually fun and cool. I don't like peri-device leaks, but it is kind of cool to close them, and I'll show you that. The mechanism of leak really determines our approach. We either coil them or put ADO2s in them. We coil if the mechanism is multiple or the leak is broad, and ductal occluder if it's focal. Now, if you look at the bottom left picture here, this is terrible anatomy. So this patient has proximal pectinate muscles that flank the appendage on both sides. And so you pretty much have to hang past the proximal pectinate muscle in order to achieve occlusion. And this is what we ended up with after 3 months. You could see a stripe of thrombus lining the device, and there's clearly a ridge side leak here. And I'm going to show you this is really cool. So we do full cardiac cycle, 8 centimeters of coverage. We do this with 4.5 roughly millisieverts. And we get full functional assessment of the appendage. And so you can see that ridge side leak. And you can look in the bottom left and see that there's only one way into this appendage. So here we go to close the procedure, for the closure procedure. Took an angio based on the CT. I tried to get back up inside this device, and I could not get in. And so we deployed, let me show this. We deployed an ADO2 in there, in the tunnel itself. And I was really happy with this. I'll go back. I was very happy with this because you look at it, contrast can't get through it. Dr. Jacob, who was doing TEs with me, if you look at the left, he didn't like it. And I was like, come on, this thing's perfect. It's perfect, don't worry about it. We're good. And then we did the CT. And then I was like, you were right. So if you look at the bottom left, it's occlusive. First thing is look at the appendage. It's dark. So did we achieve occlusion? The answer is definitively yes. The problem is the waist and the proximal disc of the ADO2 are just sort of going to be hanging out in space. So we just recaptured the device and deployed it such that the distal disc and waist were inside and that the proximal disc was pulled up tight. And this is the full cardiac cycle that we got. And then I'll show you this. This is 3 months later, completely occluded appendage. Here's full cardiac cycle. Just amazing. 8 centimeters of coverage, 4.5 millisieverts. It's amazing. You could do ice cases. We do this. I have no qualms about doing ice. It does not increase our PDL rates, as others have stated. And that's because we have the ultimate cheat code. The CT angio suite is the cheat code. So in summary, ICT guided left atrial appendage is the new gold standard. It's the definitive means of validating left atrial appendage occlusion prior to device release, such that you can change the outcome of the procedure. It's efficient. It takes 6 minutes. Patient's on the table, the fluoro swings out, the CT slides right in. We acquire, CT comes back, and we're back in business. We put a sterile drape on the patient. You could see a patient actually in there. This is a patient getting the intraprocedural CT. It's minimal radiation. We're averaging 4.5 millisieverts per scan. There's 40 cc's of contrast per scan that we're able to do these studies on. And you could fully characterize the device LAAO alignment and tissue fabric apposition. We have single-digit CT-validated PDL rates, which is pretty much unheard of. And this offers the potential to reduce the risk of stroke. And I just want to thank my team, Dr. Benton, Dr. Chaudhary, Dr. Jacob, and Dr. Harvey, and all the help we've gotten over the years from the great folks at Canon as well. So thank you very much.
Thank you, Brian. I think these are very interesting and surprising data. Do we have any question from the audience? So maybe I could start with 2 questions. The first one is just regarding your LAA closure routine and LAA closure program. Do you have some CT scan before procedure to plan your procedure?
We do CT pre-planning. If the patient's creatinine is good and they live far away and we have a fairly large outreach, we'll bring them in and do same setting. We'll do CT on the table and use that as our planning. So we do CT pre-planning and then CT validated left atrial appendage occlusion. Otherwise, I'll use any CT I have to try to get myself like, does this look like doable? And if it looks challenging, I'll get a dedicated CT. So we're really a CT program.
Okay, that makes sense. Second question is much more about the topics that we have today in this session. Is do you see potential over application in structural intervention at the top of LAA closure for this technology?
So besides that, I think this is ripe for PE, to be honest. I mean, this is like, imagine if you wanted to do, you have a CT suite and you go and we haven't done that yet, and we need to do that. So I think that procedure is definite. We are doing same setting coronary CTA PCI, which I think it's a perfect environment for that procedure. And then we've done other, kind of one-offs like closure of peri-device leaks. We've done closure of ASDs when we had a hard time, trying to figure out what was going on. We've done a number of other applications. So I think it's kind of a wide open ocean. I will say that I think it's really important to understand the value proposition of the volume scanner here. It's definitely the way to go with structural because it's single bead acquisition. And so, it doesn't matter what technology you have. Like if we try to do the same thing on any of the other scanners that we have, where it's between 3 and 5 times the radiation to get that assessment, to get that sort of block of data, and you end up with stitch artifacts and things like that. So I don't know. I'm very, very much a very strong advocate for the volume scanner and what that brings to the equation for structural heart procedures.
That makes sense. Any other question or comment? No. Well, I guess no. No, I think that's what. Yeah, we are just probably breathless and speechless. So thank you very much, and I think it's time maybe to adjourn the session. I would like to thank the audience for the presence, the Canon's Corporation for its support to this symposium, and the speaker for their excellent talk. And enjoy the rest of your PCR course. Thank you very much.